Hi, this is David Evans with AIDSMedsAndPause.com. I'm here at the conference on retroviruses and opportunistic infections in San Francisco, California. Today we're talking to Dr. Grace McComsey, who is a professor of pediatrics and medicine at Case Western Reserve University in Ohio. Welcome.
Thank you.
So one of the big topics at this year's conference is what's going on with bone health in people living with HIV, and this has been a topic of growing interest over the last several years in particular. Right. And we've found that there are various things that might be affecting people's bone health, including Variad, vitamin D levels, CD4 counts, HIV itself. Can you summarize what we know or think we know at this point?
Sure. I think we learned quite a bit at this conference. I just presented a little bit ago ACTG 5224, and that really showed us that two specific medications are more likely to cause bone disease than others. One is tenofovir, FTC, was associated with more bone loss than abacavir, 3TC.
Okay.
As well, the protease inhibitor atazanavir, ritonavir, was associated with more bone loss than efavirenz. So I think it is important to start building bone density studies in all our antiretroviral naive patients, because it's such an important topic in the U.S. now. Other things we learned from the conference, there has been other studies that have been presented and will be presented this afternoon regarding fractures, specifically fragility fractures or fractures that happen without any trauma.
Right.
We're learning that patients with HIV are at higher risk of these fractures, and it really targets us to start thinking about interventions for bone disease. So smoking not only, for example, is important for heart disease, it's important for bone. Exercise is very important, optimizing vitamin D. And that's another thing we heard a lot about at this conference, finally. Yeah. I think we're starting to do studies on vitamin D and finding that a lot of our patients are deficient. What does that mean exactly in terms of bone? I mean, we know outside of HIV that vitamin D is important for bone, but in HIV, there has not been studies to date. So we and others are planning now to look at vitamin D in the setting of bone to see if that deficiency is adding to the problem of bone disease. So we heard a lot about vitamin D in terms of how prevalent it is, and whether you look in Europe, in the U.S., in the sunny areas of the U.S. or not sunny areas like Cleveland, it seemed to be very actually prevalent.
Right. And in terms of some of the other kinds of interventions that they do in people who are not HIV positive, so for instance, postmenopausal women who have reduced bone mineral density are often put on bisphosphonates, things like Fosamax or Boniva or that sort of thing. Are we thinking about those kind of interventions for people with HIV?
Yeah, we have actually. I had shared the ACTG study looking at alendronate or Fosamax in patients with HIV who have osteopenia. And the study found it to be effective. So as expected in non-HIV patients, Fosamax does improve bone density, and it was safe up to 1 year. So the reason I mentioned the 1 year is that it's easy to say, yeah, you have low bone density, let's start you on something. But the other big question is, when do you stop? So people with HIV are going to be on meds for a long time. They are going to have the bone disease issue for a long time. We really need specific studies to tell us who exactly can benefit from these medications and how long do you give them for. But so far in the clinic, not only my clinic, I know a lot of patients or a lot of physicians, are given Fosamax or other bisphosphonates for people who have fragility fractures. So this is the easy group. If you had a fracture, you have to be on those meds because your risk of having recurrence is very high. For the other people, if you have osteopenia, so what do? We're really focusing more on the vitamin D, making sure that they don't have hypogonadism, that you can treat and improve bone.
Low testosterone.
So more, low testosterone. So more of the other interventions, not quite as invasive as bisphosphonate, but the other interventions that may improve bone. If you had the fragility fracture, that will buy you bisphosphonate for sure. And if you're osteoporotic, so remember osteoporosis is more severe form of low bone density compared to osteopenia. If you're osteoporotic, then most physicians will give you bisphosphonate because your risk is really very high. So again, all we know in HIV, it's safe up to a year. Okay. I think this is why you really need to be followed by an endocrinologist or someone who knows about Fosamax and other bisphosphonates.
Last question. So when the data that you mentioned on Viriad and Reataz, those kinds of things we're starting to learn. Do you think we know enough yet that it should change how we prescribe these medicines or decide what regimens to give to people or switch them to?
Yeah, unfortunately, studies like mine make things harder even for physicians and patients. I think all we can say is that if someone has a history of fragility fractures or a post-menopausal woman, I would try not to give them tenofovir. So if they have other options, that you could give, tenofovir would not be the first thing on my list to give them. Okay. But for people who start with a normal bone or a little bit of osteopenia, they probably will do fine. Because remember, in the study that I showed, the decrease in bone density was 2 to 4%, depending on the regimen. So it's not awful, although it's something you don't want to see, but it's not really terrible. So to answer your questions, for most patients, probably not yet. I don't think that bone should be high on the list. But for people who already have fragility fracture or osteoporosis, I would avoid tenofovir and I would avoid Reataz if you could. Now, the study compared Reataz to efavirenz. It didn't compare it to other protease inhibitors. Right. It doesn't mean Reataz is the worst among protease inhibitors. It may turn out to be the best. Okay. So we can't comment about Reataz versus other PI. All I can say, Reataz versus Sastiva or efavirenz.
Great. Well, thank you so much for taking the time.